Hello, my name is Nicole Mashburn, and I'm one of the anatomy and physiology instructors here at Calhoun. And today I'm going to talk to you about blood pressure and blood pressure control. So we'll get started. We're going to talk about what is blood pressure. Pressure is basically a force exerted on something else. Okay, so blood pressure is just the pressure of the blood exerted on the wall of a blood vessel. So the pressure of the blood on the wall of a blood vessel. So how hard or how much force that blood puts on the wall of a blood vessel. It's expressed as a systolic over diastolic pressure. It's always measured in millimeters of mercury, and it's one of your principal vital signs. When you go to the doctor's office, they'll measure your temperature, your pulse, your blood pressure. They measure your glucose levels. But blood pressure is always a principal vital sign that they will take when you go to the doctor's office. It's basically the driving force that keeps your blood moving from an area of high pressure to low pressure. This is our diagram. We have the heart. Okay, blood flow is in this direction. So the heart is contracting and forcing the blood through the arterial system into the capillaries, and then the blood will return to the heart via the venous system. Now, when we talk about blood pressure, we're talking about arterial blood pressure. And we're talking about the highest blood pressure, which is usually in a vessel near the heart. So when you take blood pressure, typically you take it in your arm, which is in a vessel close to the heart. This is where your highest blood pressure will be found, coming from the aorta, then going out into the arm. The blood pressure will slowly decrease as you go toward the capillaries. Small amount of blood pressure in the capillaries, and then very little as you come through the venous return. Now, when you talk about this blood pressure, we're talking about arterial blood pressure in the arteries near the heart. You talk about systolic pressure and diastolic pressure. Those are the two terms that you hear in reference to blood pressure. The systolic pressure is the maximum pressure exerted during ventricular contraction. The diastolic pressure is the minimum pressure exerted during ventricular relaxation. Now, typical systolic pressures can range anywhere from 90 to 140 millimeters of mercury. Diastolic pressures can range from 60 to 90 millimeters of mercury. Blood pressure will cycle throughout the day. In a 24-hour period, your blood pressure will cycle and go up and down all throughout the day. It is typically higher in the morning, and this is due to various hormone levels that you'll learn about when you talk about the endocrine system. When you take a blood pressure, if you're trying to monitor your blood pressure, they'll ask you to take it first thing when your feet first hit the floor. Take it first thing in the morning, then take it in the afternoon, take it in the evening, and just kind of see what your daily range is, because it will fluctuate throughout the day. It can also vary based on your age, your sex, your weight, race, mood. If you're angry or upset, your blood pressure may go out or may go up. Your posture. If you ever gotten up too fast and you felt like the blood just drained from your head and you just kind of felt woozy, that can happen. You can lower your blood pressure by getting up too fast. That's called orthostatic hypotension. Your normal blood pressure range is 120 over 80 millimeters per mercury. If you have a reading that's anywhere 140, 190 or higher, that's considered hypertension, and typically that's going to require treatment. If your systolic blood pressure is below 100 millimeters of mercury, that's hypotension, and typically that's okay. Actually, long life is associated with hypotension. If it's too low, it may be pathologic, but low blood pressure is always better than high blood pressure. Now, how do we maintain our blood pressure? It's going to cycle throughout the day. How do we try to maintain those homeostatic levels? Basically, it requires three things to cooperate. And for these things to cooperate, they're all going to be supervised by the brain. You've got to have your heart playing a role, your blood vessels, and your kidneys. Now, for the heart, we're talking about cardiac output, and hopefully you've already covered cardiac output. Cardiac output is your heart rate times your stroke volume. You're talking about peripheral resistance of the blood vessels, how contracted, how vasoconstricted or vasodilated they are. And you're talking from the kidneys, blood volume, how much blood volume you have. You're going to regulate that with your kidneys by increasing or decreasing urine output, and that's going to affect blood volume. Okay, so we know what cardiac output is. We know what we sort of know what the kidneys do. We'll talk about that more later on in 202. Let's talk about what peripheral resistance is. Okay, basically it's opposition to flow. It's the friction. It's the amount of friction that the blood encounters as it goes through the peripheral circulation. Okay? There's three sources of this friction, and I use the 3 V's: viscosity, vessel length, and vessel diameter. The viscosity is the stickiness, or how thick the blood is. Think about if you had a hose that you put in, chocolate pudding versus water. One of them is more thick than the other. The pudding is really thick. It's going to put in a lot of force, okay? It's really sticky. The vessel length, how long the vessel is. The longer the vessel, the greater the resistance. And vessel diameter, how big around the vessel is. The smaller the vessel, the greater the resistance. So viscosity, vessel length, and vessel diameter all play a role in controlling peripheral resistance. Now, you can't necessarily change the vessel length, but you can change the vessel diameter, and you can affect the viscosity by changing your blood volume. All right, so how do we control this blood pressure? Blood pressure varies directly with cardiac output, peripheral resistance, and blood volume. If you change one, there are compensations quickly made, short-term changes, to keep your blood pressure stable. So let's just have our blood pressure, our homeostatic level of blood pressure, let's just say it's normalized, hanging out about right here. What happens if you increase your heart rate? If you increase your heart rate, you increase your cardiac output, you increase your blood pressure. If you increase your stroke volume, you increase your cardiac output, you increase your blood pressure. But if you increase the volume, blood volume, just increase the overall amount of blood you have in the vessels, there's just more blood there. If you do that, you increase your blood pressure. If you increase the blood viscosity, make it thick, make it sticky, that increases the peripheral resistance, that increases the blood pressure. Now, diameter, blood vessel diameter. What happens with that? If you decrease the blood vessel diameter or vasoconstrict, so decrease the diameter or vasoconstrict the vessel, that's going to increase peripheral resistance and increase your blood pressure. So all these work together to maintain your blood pressure at a homeostatic level. Now these are considered, we have short-term and long-term regulations of blood pressure. Your short-term regulations are basically neural and hormonal. Neural, nervous system, think brain. Okay, hormonal, endocrine. And these are endocrine. These are short-term changes to maintain blood pressure. Your long-term changes are renal or kidney. They're changed by the kidney. Now your short-term controls, they counteract fluctuations by altering peripheral resistance. Okay, they counteract the fluctuations in blood pressure by altering the peripheral resistance. Maybe vasoconstricting or vasodilating, things like that. Long-term renal regulation by the kidney, that works by counteracting these changes in blood pressure by altering the blood volume. So you have changes in peripheral resistance, short-term, changes in blood volume, long-term. Let's talk about some of those controls, these neural controls. You may alter the blood vessel diameter, that would change peripheral resistance. You may change the blood distribution, that would change blood volume. Let's think of some times you might change your distribution of blood. For example, when it's cold outside and you have vasoconstriction of your peripheral vessels, that shunts the blood to your core to keep you warm. When you exercise, you shunt the blood away from your digestive system out to your muscles to make you more effective when you're running or exercising. So these changes, these shunting of blood from one part of the body to the other, can change the blood volume inside those vessels and change your blood pressure. You have additional neural controls, the baroreceptors. These are basically stretch receptors. Okay? And these help control vasodilation and vasoconstriction. There's just like a feedback mechanism, which I'm going to talk about. You also have some short-term control by chemoreceptors. These are just sensors in your body that measure changes in CO2 level, drops in pH, and changes in oxygen level. So if your body senses a change in the CO2 level or a drop in oxygen, it's going to have your body increase its heart rate, increase respiration rate, things like that, to normalize your blood pressure. All right, so hopefully you remember from 201 homeostasis and the negative feedback loop. So this is an example of homeostasis and two negative feedback loops. One's to decrease your blood pressure and one's to bring your blood pressure back up. So here's homeostasis. Your blood pressure is in the normal range. What happens? What's the stimulus if blood pressure begins to rise? Rising blood pressure is the stimulus. This blood pressure, this force against the wall is going to stretch these baroreceptors in the carotid sinus and the aortic arch, and that's going to send a signal or an impulse to the brain. That's going to stimulate the cardiac inhibitory and inhibit the cardiac acceleratory systems in the brain. The brain, because your blood pressure is too high, we've got to get your blood pressure back down. The brain is going to say, okay, send a signal to the heart, send a signal to the blood vessels. It's going to slow down heart rate, slow down contractivity, slow down cardiac output. It's going to send a signal to the vessels, have them vasodilate. That decreases what? Peripheral resistance. If you decrease cardiac output, you decrease peripheral resistance, you bring your blood pressure back down. Now what happens if the blood pressure is falling? Your blood pressure is going too low. Okay? These are no longer stretched. The signal to the brain is, blood pressure is too low. We've got to get the blood pressure back up. Send a signal to the heart, increase sympathetic activity, increase heart rate, increase cardiac output. Tell the blood vessels to vasoconstrict, increase peripheral resistance. So you're increasing cardiac output, increasing peripheral resistance, increasing blood pressure. Okay, and these two systems work hand in hand all day long, keeping your blood pressure at a homeostatic level. Now, sometimes you have to go into long-term mechanisms. These baroreceptors are going to adapt quickly. They just they get worn out or used to chronic high or chronic low blood pressure. They don't respond as well anymore. So you've got to go to long-term mechanisms. And when we talk about long-term mechanisms, we primarily are talking about altering the blood volume. When we talk about altering blood volume, we're talking about the kidneys. So the kidneys can act directly or indirectly. Directly, they will alter blood volume. Think about urine output. Okay. Indirectly, they're the renin-angiotensin system. And these are going to be a lecture for another day. You're going to hear a whole lecture on long-term mechanisms. I'm just introducing it to you. Now my last slide, this is a really complex slide, but it shows you just how complex blood pressure really is. There's a lot of things that go on with blood pressure to keep it regulated. Up here you have all your stimulus. It could be body size, dehydration. What would you expect with dehydration? Your blood would be more sticky, right? If your blood's more sticky, you have higher blood viscosity. That's going to increase your peripheral resistance, increase your blood pressure. Okay? What if you're just really, really tall? Really, really tall, long blood vessels, long peripheral resistance, blood pressure goes up. What if you've got, these are some hormones, things like that, they may actually cause vasoconstriction of the blood vessels, increase peripheral resistance, increase blood pressure. You increase stroke volume, increase heart rate by excessive sweating, temperature, increase heart rate, increase blood pressure. So it's very complex. Lots of different stimuli can have an effect either at the peripheral resistance level or the cardiac output level and increase your heart rate. If you have any questions about this, please come find me, or any of your instructors will be glad to explain this to you further. It is a complex system, but it's a lot of fun once you get the hang of it. Thank you for your attention and have a great day.